So I wanted to update this brief presentation. I'm 4 years on now being a primary care network clinical director, been there from the start, and we've had lots of experience as peak health coaching, training and supervising a range of these new additional roles, these person-centered care roles. And I really wanted to just sort of talk about how this fits together in the current context. But let's start off with thinking about what there is to gain. What feels really important at the moment is that our staff are flourishing in their jobs. We know from Michael West's work that the quality of care is really dependent on people feeling like they're doing meaningful and manageable work. And of course, we all want to feel like we're pulling together, don't we? Whether that's a team of staff or whether that's patients working with their professionals, communities working with services. It's really important we feel like we're on a team together. And if the team's working well, the system flourishes. And for me, it's that lovely balance, isn't it, between the mechanics of the system and the people that are working in it. And, right now we want stuff to celebrate. We want some optimism and hope, don't we? Healthcare should be about flourishing, not about the grind. So let's go back to those famous bubbles that I've been talking about before and update where I'm up to. So, of course, we've got our primary care team, haven't we, who are diagnosing and excluding things, of course. They're prescribing and, importantly, now de-prescribing as we realise the limits of medication. And they have a really important part to advocate for person-centred care. It's valuable and important in the mix. And, of course, they pick up the acute stuff, the real nasty emergency illnesses that need sorting out straight away. Then we've got our growing coaching teams, haven't we? Groups of both volunteers, peer support and paid professionals, a growing workforce that is skilled at building rapport and trust, raising people's self-confidence and helping them to think well and then change their behaviour to improve their health. And in the in-between, between the primary care teams and coaching, we've got this ability to make really good care plans and to support self-management. Then we've got our growing social prescribing link worker teams, haven't we? Very much in the places where they're working, focusing on asset-based community development. They're managing the directories and building services of things that are available in the community. And they track and assess what activity is going on. And of course, their interface with primary care is that they assess social need, people's wider determinants of health, or social determinants of health, as Michael Marmot calls them, and help people to engage with things that will help their health and well-being, and they connect them with those community assets. And between link workers and the coaching teams, you've got this ability, haven't you, to do things together in groups. There's a real power, isn't there, of peer support, people like you working with others who want to help each other and support each other. And that growing ethos is really powerful. I see that working on the ground. And of course, in the middle, you've got this increasingly important role of care coordination, where you coordinate multiple morbidity, multiple health problems with people's need to access things in the communities where they live, and to take that coaching style approach that builds people's own capabilities to do things no matter what stage of life they're at. And of course, wrapped round the link worker team, you've got all those other community-based agencies that build people's employment, their housing, social services, and very importantly, the community assets, those formal community anchors, or those informal groups, clubs and associations that make up the magic of our communities. And, perhaps in the overlap between the community and the healthcare team, you've got the other community teams, the community therapy teams, the nursing teams that we really want to wrap into this. And increasingly, I'm seeing as a clinical director in a primary care network that we see teams within the PCN. We've got, for example, a community mental health team that sits across, what primary care does and this coaching and community social approach. And you could put in there, a pharmacy team. You could put in there, a physio team. There's a range of teams that sit in there, really building value into the system and overlapping. Of course, one of the issues I have really is how we deal with the specialist teams, the hospitals and the consultants. And one of the things, the dynamic we see is that primary care generally has a referral relationship. So we're feeding people into the specialist teams. And one of the troubles with that, if you're not careful, is that it can almost feel like that community team gets sucked into the specialist approach. It becomes very medicalised, and we hold our value related to that medical model. And what I am seeing really is that the real true value of this primary care team, this integrated approach, sits in spanning the gap between the specialist approach and real life people and communities. And I think these three person-centered care roles are helping us to reclaim that balance, to draw this integrated team back so that it sits spanning equally in a kind of very valuable space between these two. So maybe what we hope to see is that the specialist teams integrate with our community team. There are, of course, things that they do themselves, but actually, they should increasingly be thinking about a coaching style approach to what they do in their specialist settings. And let's not forget the really important role that patients themselves play in patient-led peer support. And we're certainly seeing that in our network, where we're seeing patients increasingly taking a lead in group working and in running community groups and assets. There are such an important ingredient in this whole ecosystem we're building. And maybe this is what an integrated neighbourhood team looks like. Is this what we're striving for? I don't have all the answers, but certainly we should be thinking about how we, reclaim the prestige of doing this really, really well. I think this is what primary care has always championed, and I think we should be really sticking our hands up as primary care and the integrated teams we're creating across health and social and coaching approach as being the kind of, if you like, it's the real quality and the real high performance aspect of the medical system that we should reclaim, I think. And a final footnote from someone I really respect, Elaine Cross, who's a national peer champion, and she looked at this and she said, Ollie, you know what, the patients, and let's not forget unpaid carers in that, should be sort of sitting across the whole thing really. They should be in all aspects of this, and credit to Elaine with her thinking on that and how she holds us account to that. So thank you for that. And thanks for every patient and peer supporter that gets involved. It's just enabling us to make this a whole different approach. Because at the end of the day, I think we are all the NHS. We can't rely on services to do things to us. We have expert professionals that support us, but together we are all the NHS.